Hello and good evening, and welcome to this evening's Facebook Live. My name is Alec O'Dare. I'm the MD for Wound Care People and Wound Care Today. This evening's session is pressure ulcers, the newly vulnerable. And I'm very pleased to announce that this evening's speaker is Jacqui Fletcher, who's an independent nurse consultant, a prolific author. I've been involved in numerous global studies and consensus documents and lots of other things. I'm really pleased that we've got her here. I'll be introducing Jacqui in just one moment. But firstly, I'd like to just go through a little bit of housekeeping. So I'd like to thank Mölnlycke for their support. I'd like to thank each and every one of you for joining us. It's 25 degrees here in Cardiff this evening, so it's a very hot evening. And I know that I've just spoken to Jacqui and it's 31 degrees where she is. So I'm sure that so we're very grateful basically for your support in joining us. Throughout the presentation, do send in lots of questions by commenting on the video or sending questions directly. We'll get through to those at the end of the presentation during the live Q&A. Certificates will be available at the end of the presentation via a link that you'll be able to see and click on your screen. Before I hand over, Jacqui, are you there? How are you doing?
Hi, Alec. Good evening. Yes, I'm here. Makes it sound like I'm somewhere really exotic saying it's 31 degrees, but I'm only in Bedfordshire.
I know, but you're closer to London than I am, and that always seems to be the hottest place of the year, doesn't it? So,
it does.
Not
I think
of the year, of the country. So, Jacqui, thank you very much for joining us. We were talking earlier this afternoon. I said that it's been I've been in this industry for 12 or 13 years, working either in publishing or in the industry side of things, selling dressings to nurses and various other things. And this is the first opportunity that we've had to work together, and I'm really pleased about that. So rather than waste any more time with chit-chat, I'm going to hand over to you to do the presentation. I'll come back and join you afterwards, and we'll get to the live Q&A.
Thanks, Alec, and thank you to Mölnlycke for supporting this session. So what we're going to talk about this evening are pressure ulcers in the newly vulnerable. And what I want to start with doing is just outlining what we're going to cover. So we'll obviously start with a little bit of a description of what it is we're talking about, what a typical pressure ulcer is and where it might be. And then moving on to how COVID-19's changed the landscape. And I'm guessing for many of you, you've seen significant changes in what's happened over the last 6 months. We'll discuss how those at risk have changed and how risk itself has changed and how we might protect those newly vulnerable client groups. And then think about how we might put pathways together to start to consider doing better prevention and being consistent in what we do. So I'm going to start with this definition, which hopefully many of you are very familiar with. It's based on the 2014 international guidance by the European and American and Pan-Pacific definition groups, but it was adapted in 2018 by NHS Improvement in our revised definition and measurement. The only adjustment we made was to add in the information about the devices. So when we're talking about pressure ulcers, we're talking about localized damage to skin and underlying tissue, most commonly over a bony prominence. But what we've seen more recently, particularly with the emphasis on critical care and on staff wearing PPE, is a lot of pressure ulcers related to medical devices. And importantly, we know that that damage occurs not just from sustained pressure, but also from shear forces. And shear forces are something that's kind of newer in the literature than pressure. But it can present as intact skin or an open ulcer. And more importantly, for the patient, they can be incredibly painful. And you can see here some typical examples of pressure ulcers. I'm guessing many of you have seen pressure ulcers in your practice. I've tried to pick some middle of the range ones. So these aren't the worst ones I've ever seen. These aren't the most superficial ones that I've ever seen. And I would like it if you can join in as we go along, maybe tell us of some of the pressure ulcers you've seen and what the challenges have been. But what you can see is that these present against the two most common areas of pressure ulceration. So the most common place we see pressure ulcers are across the sacrum, anywhere in that pelvic region. And the second most common are at the heels. Both of them obviously are very bony prominences. And if we look at what's happened in the world of preventing pressure ulcers, there's really been considerable change within this century. So since 2003, we've started to look at how we can capture data on pressure ulcers. In 2006, we saw an attempt made by an organisation called Your Turn to try and engage patients, families, carers much more in pressure ulcer prevention. So this wasn't just a thing that nurses and other healthcare professionals dealt with, it was something they could take responsibility for themselves. And then in 2010, we saw the first attempt in England at national measurement with the introduction of the patient safety thermometer. Many of you will be familiar with this. So on the second Wednesday of the month, filling in the safety thermometer to report how many patients you have in your care with existing pressure ulcers or newly developed pressure ulcers. You may be aware that safety thermometer is no longer in place for pressure ulcer prevention, and we are seeking new ways to start to monitor pressure ulcers. Within the acute setting, so in hospitals, we're looking at using HES data, hospital episode statistics, and in the community, we're looking at using existing electronic patient records and seeing what we can mine from the coding. The Stop the Pressure programme actually started in 2011 in the east of England, later to become the Midlands and East Strategic Health Authority, but it was very much a regional initiative. And our then chief nurse later became chief nurse for England. And prior to doing that, she managed to make Stop the Pressure a national initiative. And because of that, we've had for the last 3 or 4 years a whole programme dedicated to trying to prevent pressure ulceration across England. As part of that, and as part of the National Wound Care Strategy work, we've also seen a programme aimed much more at nursing homes and care homes, at social care and patients and carers, which is React to Red. But these are all based on the same fundamental underpinnings. So many of you might be familiar with the Siskin bundle, but in 2018, we extended, so it's now at the ASKING bundle. So the A being for assessment of risk, the S for skin assessment, the second S for your support surface, the K for keeping people moving, the I for increased moisture, particularly incontinence, the N for nutrition and hydration, and finally the G for the giving of information. And these are the core principles which we try to follow in pressure ulcer prevention. We have this year seen a significant change in what we do around pressure ulcer prevention and in the patients that we've got. And it'd be interesting to hear your perspectives or your experience on what you've seen in terms of pressure ulcers that happen to patients, or even whether you've experienced pressure ulcers yourself or your colleagues have experienced pressure ulcers in relation to use of PPE. We do know that the demographic of the vulnerable patients has changed significantly because of COVID. And we have a whole host of what we call newly vulnerable patients. If we take patients who've been diagnosed with COVID as a group themselves, they are often acutely unwell, particularly if they require hospitalisation. So there may be many of you work in community who've seen patients with COVID who have been chronically unwell, but not acutely unwell. But you'll be very aware of the number of patients who are making it through into intensive and critical care and the acuity of that illness. And the things that put them at risk of COVID and that acuteness is their predisposing conditions. Many of those same predisposing conditions are also what make them at risk of pressure ulceration. So there are multiple comorbidities, particularly things like respiratory disease, immobility, obesity, diabetes. But we also know that in the COVID patients, we are giving them many drugs and nursing them in different ways that increase their risk. So for example, proning patients, nursing patients on their fronts is something that's unfamiliar to many people. Certainly it's a position I prefer to sleep in, so I don't know how many of you like to sleep on your front, but if you're a back sleeper, being put on your front can be quite claustrophobic. And when we talk about prone, there's an assumption that that only applies to the intensive care patients. But actually within the COVID pathway, we are using prone for conscious patients as a treatment to help improve their respiratory disease. And in putting patients on their front, we are exposing very different areas of the body to risk of pressure ulcers. So we're looking at the collarbones, we're looking at the breastbones, the ribs, the fronts of the hips, the knees, the genitalia in particular. We're struggling to keep long lines out of the way and catheters out of the way. But aside from the patients with COVID, we're also seeing what happens to patients who are impacted on by what's happening within the acute services. And this might be patients experiencing delays in emergency or planned care. So for example, somebody who would be of the right age to undertake bowel screening, at the minute, bowel screening has been withdrawn, it's not happening. And even if you did complete your bowel screen immediately prior to COVID, it's highly likely that you're only just going for your colonoscopy should something have been found. and that further screening will take a little while longer. Equally, some of the patients who are very vulnerable, so for example, patients who've got cancer and might have been having radiotherapy or other oncology type treatments, have been very reluctant to come into hospital. They've been very scared, very anxious, because they know they're very immunosuppressed, particularly if they're on chemotherapy. And I certainly, in my time working in acute during the COVID period, saw at least 5 patients who were post-chemotherapy and were incredibly unwell, but were desperate to not be admitted because they were very scared of what would happen to them. Another group are the healthcare professionals. And there's 2 things here. There is a group of healthcare professionals who have been shielded. And that's quite frustrating for many of them. They feel they can contribute, but actually they're being kept at home. And many of them feel there are other ways they can contribute. So they've been rewriting policies, doing teaching plans, viewing wounds digitally, doing a whole host of things, but they feel sometimes they're letting their colleagues down. And there are others that are redeployed, and that redeployment in itself exposes us to a whole host of other problems. So for example, in the intensive care unit where I was working, they were very well supported with extra staff, but those staff came from areas like theatres and from outpatient departments, which meant that the actual intensivists, although they had hands, they had bodies, they were very anxious about the level of acute care that was being delivered. And they often finished up keeping their PPE on much longer, not taking their breaks, because they wanted to oversee the care that was being delivered. There are other groups that are also clinically vulnerable, and certainly we've only seen within the recent last few weeks, particularly the elderly patients and those people who are fully shielded starting to come out of their homes. And I know from my own street, there's an elderly couple in their 90s who live across from me, who were very anxious about coming out for the first time, very worried about what they were exposing themselves to. And there are also professional workers requiring personal protective equipment, and we'll talk about that a little bit more later. But let's not forget, it's not just the acute service, and there's been a lot of focus on hospitals. We can't forget our colleagues working in community, our colleagues working in social care, our colleagues working in nursing and residential homes, and all sorts of other specialist care in supporting people to live life as well as they can. And you might want to think, what does that mean for you in terms of your clinical practice? So what are you seeing happening with your colleagues? What are you seeing happening with your patients? What does it mean in terms of your professional role? And for any of you, as this overlapped in your personal, or wearing a mask under their nose or under their chin, how does that make you feel? How does it make you want to engage with them? And certainly, how do you feel about people who we know are vulnerable and may not be able to wear a mask for a real reason? And that may be claustrophobia, it may be respiratory disorder, it can be a whole host of things. How do you stand up for that person and help them when they most need it? We've certainly seen a change in patients who we would deem to be at risk. And that may be these newly vulnerable people that I was talking about, or it may be people who we previously classed as at a lower risk because although they were elderly, they were active, but now because they are in a different situation, because they're shielded, because they're confined to their home, they've become much less active. And that reduction in activity can also lead to things like depression, which in turn increases the lack of activity that they have. We might want to think about a young, fit patient who's had COVID and what impacts that has on them, particularly in terms of their self-esteem or ongoing tiredness. And we are increasingly seeing that the ongoing impact of COVID is not 1 or 2 weeks, it's 3, 5, 6 weeks, sometimes several months. And what impact does that have on them when they're trying to maintain their role as a parent, when they're trying to maintain their working from home? We also know that being in critical care has a significant impact on a patient's well-being and psychology. And if you've experienced being in critical care yourself, or if you have a relative who's been in critical care, particularly if they've been intubated, if they've been kept in an artificial coma or in a coma because of their medical condition, it's very disorientating when they come round. They've lost long periods of time and they find it hard to acclimatise to that. They're unaware of what they and what their relatives have been through. In some ways, the relatives are more traumatized. And I think particularly in this situation where relatives know that their one they care about is critically unwell and they're not able to visit them, that's very stressful for them. We also have the people, the survivors, the people that have done well and recovered. But what we are seeing is an element of almost post-traumatic stress. They know what they went through and they know how lucky they were. And they saw many others who were not as fortunate. And we're also seeing a group of people who are suffering facial damage due to PPE. And that can be healthcare professionals or others. And there's a whole host of emotions that go with this. That can be anger because they didn't get the right equipment, or anger because they weren't given the right guidance, or they didn't feel supported. And it can be people feeling very helpless or not knowing what they're meant to do, or being put in very difficult situations. So for example, Alex started off by telling you it's 31 degrees where I live today. My son is a scaffolder and he works in London. And he's been on the 18th story of a building in his normal full PPE, which is all the high-vis, you know, the kind of dungaree type things and high-vis t-shirts. But he's also been having to wear a mask and a visor. And he's carrying scaffolding up and downstairs because they haven't yet installed the lift shafts. So if you can imagine what the impact of that extra PPE is for people, it's not just the heat, it's the not being able to catch your breath, it's the edema, it's the sweating, and all those things can also start to damage your skin. I'm guessing many of you have seen images like this, if not these ones themselves. And these are examples of two nurses who posted on social media the impact of wearing PPE for extended periods. And there's a whole host of political things we could go into behind this. And I don't want to make this a political discussion. But we need to think about how these nurses found themselves in this situation. Was it because there was a lack of equipment, so they didn't take the mask off and change it because they knew there wasn't a new one to put on? Was it because they'd been fit tested on one mask and they had been given a different one and it wasn't the right size for them? Was it, as I mentioned with my intensive care, that they didn't take a break because they were the only intensivist within that bay and they felt that they needed to oversee what was going on? And it's very clear from some work that's been done with the University of Southampton that one of the things that is a real marker for skin damage is not taking breaks. So University of Southampton, the Medical Devices and Vulnerable Skin Network have done a survey of skin damage from quite a large cohort of people. And however you look at it, a 3-hour point is if you don't take a break before 3 hours, you are much more likely to develop damage to your skin. And equally, we know many people were working additional shifts, so they were working 10 days back to back because we were very short staffed, because so many people were self-isolating or shielded, other staff were having to cover. And again, that doesn't allow the skin time to fully recover. And what we saw in clinical practice to try and cover these gaps was a whole host of people that were not doing what they were meant to be doing, whether that was third-year student nurses working as registered nurses, or healthcare professionals working in different fields. So we saw podiatrists taking on lower limb care up to the knee. We had many podiatrists who quickly learned how to apply compression, whether that was wraps or hosiery or some simple systems of compression bandaging, in an attempt to reduce the number of people going into each patient's home. We had other therapists working with us. So in the hospital I worked at, on lots of the wards within what was normally the nursing team, there were OTs and physiotherapists helping deliver basic care, helping to reposition patients, feed patients, because they weren't delivering outpatient services or rehab services because those were paused. And if you look at what happened in community, what we saw was a whole different group of people being brought in to support the district nursing teams. So we know that there were many school nurses brought into community nursing teams. Once schools were closed down, they had no work to do. So they put them in to support the district nurses. Now, school nurses do an amazing job, but it's a very specialist job. It's certainly not what your average community nurse would be doing. So the community nurses were taking on the really specialist tasks and working very hard with that. And the school nurses doing anything that they could pick up, anything that they could learn quickly to support the community nurses. On the other side of that, we also saw being redeployed into community nursing teams and also onto ward teams and the tissue viability nurses. So we've got a few examples where TVNs in acute were redeployed into proning teams to help flip the patients and look after their skin. But equally, we saw TVNs who were redeployed into community nursing caseloads. And as you can imagine, what very quickly happened is the district nurses went, here you go, take all my patients with the wounds, which for the TVNs has been a really great experience. It's given them time to work much more closely with the wound care patients. It's given them time to review lots of care plans that they wouldn't normally have and see much more to firsthand what's happening in community. But as we start to get back to work, and even through some of the main COVID period, we're seeing other people, public-facing people, needing to wear PPE. And I just want to reiterate at this point, when I'm talking about PPE, it's not just about the masks and visors. We mustn't forget things like gloves and hand washing and the impact that that has on skin. So as well as the damage to the faces we're seeing lots more people reporting high incidence of eczema. We're seeing lots of dry, cracked skin. And we're really having to work hard to get people to keep washing their hands, but to not overwash the hands, to make sure when they do hand wash that they dry their hands properly before they put them into gloves, that they dry the gel properly before they put the hands into gloves, because that's when problems start to occur. And for healthcare professionals and for all these other people, communication has become a real issue. So we've started to see popping up on social media, people making masks with clear bits in the middle so that people who lip read, people who are deaf, can see. But it's not just for deaf people. I think most of you will have noticed that it's much harder to understand people who are wearing a mask. And it's not just that it's muffled. We forget how much we rely on facial expression. Just being able to see if somebody's smiling or not smiling is really important. So there's been a huge impact on communication for people. And we've also seen lots of kind of the visual cues that we would normally have lost. Lots of people are very red in the face. They're red in the face because they're hot. And they often look quite angry because all you see is a shiny, hot red forehead. And that does make communication difficult for people. So I've mentioned facial skin damage quite a lot, and I think it's important to say it's not just about pressure ulcers, although obviously we are very interested in pressure ulcers. What we've seen in the Medical Device and Vulnerable Skin Network reports is a whole host of different types of skin damage. So there are pressure ulcers, primarily pressure ulcers across the bridge of the nose and behind the ears, but we've also seen redness, irritation, dry skin, and a lot of spots. And the spots, the increasing spottiness tends to happen around the chin. So even if you're wearing a surgical mask, what you see is you get all that moisture from the breathing collects in the lower reaches of the chin. And I think that in itself is an important point. We're not just talking about the FFP3 mask here. We are talking about any mask that's being used for longer than 3 hours and not replaced. So the skin areas vary. The ears are actually quite a difficult thing, and we've seen problems with ears because whichever kind of equipment you're using, there seems to be an inconsistency in the way we tie them. So we have the actual ties, the like ribbon ties, we have the flat elastic, and we have the rolled elastic. And you then get into problems with what if somebody's wearing glasses? What about if they've got safety glasses on or visors? What if they've got you're trying to get oxygen in there as well? So I was part of a patient transport team. And when we moved patients about in the corridors, the respiratory patients, even if they'd got nasal oxygen on, they had to have a mask over the top of it. And it was very, very difficult for them with all these things going on behind their heads and their ears. And if, like me, you need your glasses to read, to see to read, or to check people's skin, but you can't walk about with them on, you then get into this constant problem about, well, I've got my mask on and I've got my visor on. How do I lift my glasses up and down without breaking the rules of the PPE, without the not touching that you need to do? And we have produced guidance. There's lots of different guidance, but actually very little evidence that goes behind it. So when we at NHS Improvement wrote our guidance and said we need to take breaks between 2 and 4 hours, we were kind of just pulling that out from people's opinion of what we knew. And now we've actually got evidence from the survey done by Southampton that does seem to be the same. But there is guidance produced from lots of different places. So for example, the Canadians, the Portuguese, the Americans have all produced their own. We at NHS in England and NHS Improvement have produced our own, and there are distinct differences between them. Some of them reflect how quickly the guidance was done. We learned an awful lot. China was very quick to start publishing data on what had happened, what had gone well, what had not gone well. But we know that will probably change. If we go into a second wave, we're already looking at the guidance that we've got and what changes we need to make to that. You will see that there's been a huge amount of information in the media, both professional and general media, about raising the profile of these newly vulnerable patients. So I've already mentioned the NHS England and NHS Improvement work. Some of you may be familiar with a document called Secure, a consensus document that was put out around about March time. And this was a consensus document about prevention of device-related pressure ulcers. This was work that was done at the end of last year. It was nothing to do with COVID. It was purely about devices. But actually the team that did it adapted that and put out a second iteration really quickly to help us to start to look at what was going on with healthcare professionals and other people wearing devices, not respiratory devices. You can see lots of guidance locally, whether that's from your local NHS organisation, or guidance in things like that. You can see a Woman and Home magazine telling you how to make masks, what you expect from that. And there's lots of things on YouTube and on Facebook about what a mask should do, how it should be handled, how it should be washed, and how to wear it. So what else can we do, and what is the best thing to be doing in terms of preventing skin damage in these newly vulnerable patients? And particularly in terms of our colleagues who are wearing PPE. The basics apply. Good skincare is really important. So the basis to any equipment being applied is make sure the skin is clean and dry and well hydrated. The guidance we produce suggests regular use of moisturiser morning and evening, with a caveat that if you're going to apply moisturiser, please do make sure that that's done at least 30 minutes before you apply the mask to allow that moisturiser to sink into your skin. We don't want it sitting on the mask because it can either degrade the mask edges itself, or it can make the mask cause further damage. We need to make sure that if you know you're going to be wearing a mask for any length of time, that you apply additional skin protection in the form of a skin barrier film or a skin barrier cream. And also, as with the moisturizer, you're making sure that that's dried, that it's not going to be sticking to the mask or make the mask stick to your skin. But the most important thing, and I think this is probably the third time I'm mentioning it because it's really important, is the physical removal of the mask. The taking that off at regular intervals, making sure that the skin has a chance to recover. And we're not generally recommending reusing of masks, although we do know that it's happening. So if you do clean your mask because you're going to reapply it, make sure that whatever you cleaned it with has dried off. The guidance currently suggests that we shouldn't be using dressing products underneath our PPE, because it's believed that that can impact on the seal and on the fit of a mask. And if any of you are wearing a mask, you should be having a fit test. And what I would ask you is that if you have had a fit test, do you know the name of the mask that you were fit tested on? And the second question is, if you know the name of the mask you were fit tested on, is it still the same mask that you're using now, or has your organisation changed to a different brand of mask because of cost, because of availability, or just because they find it's better? Our belief is that many people have no idea of the name of the brand or type of mask that they were tested on. And certainly my experience working in an acute organisation for 14 weeks was I probably had used about 8 different masks, although I was only fit tested on one. So if we are thinking about protecting the skin, if we are thinking about putting any dressing products underneath, we need to be really careful about what that is. We need to make sure it doesn't affect the fit of the mask, the stability of the mask, and we also need to think about what we think the product is doing. So I've already mentioned skin barriers. The role of a skin barrier is to protect the skin from the moisture, from the sweat that gathers inside the mask. It will do nothing to prevent pressure ulcers because it doesn't reduce the pressure in any way. When you are thinking about putting something under a mask, what you should really be thinking about is something as low profile profile as possible. So don't be using the polymer gel shaped products that are really thick. Although they are good for preventing pressure on heels and elbows and all sorts of places, they are much too thick to be used under a mask. You want, if possible, to have something that's got a tapered edge. So although it may be a little bit padded in the middle, it's thinner down the edges. And if you're going to use anything that's adhesive, I would really caution you to make sure that you're using a silicone gel. Because in the same way that you remove your mask, you should be removing the dressing product because it's as contaminated as your mask is. Unfortunately, we are in a situation at the minute where the health and safety executives still continue to tell us that no dressing should be used between the mask and the skin. But we are trying to go back to them to argue the case for that, to say we need to think about our staff's health and well-being. If somebody is fit tested and they fit tested and the mask doesn't fit, my experience, I know the experience of some of my other tissue viability colleagues, is actually once you put a dressing in situ, depending on the person's face shape in the first place, you sometimes achieve a better seal. And we've seen that with some people who did have a fit anyway, but got sore skin, maybe a small break in the skin, and they applied a very thin, low profile dressing. And we refit tested them as you should, and we still saw they had a seal. So although I can't recommend the use of dressings, I'm saying I know they happen, but the important fact is you must always recheck with a fit test, not a fit check, that the mask is still working for you. So in all of this, in terms of pressure ulcer prevention and management of these newly vulnerable people, the role of the nurse is very much remembering to flag who is vulnerable, remembering that risk assessment might have changed. So whether you're using Waterloo, Braden, Purpose T, whatever it is, we also have to think about an element of common sense and an element of being aware of what's changed in COVID, being aware of how we've changed our practice and who's delivering practice. We have to make sure that we are up to date with our education and that our colleagues are. So for example, I spent a lot of time working in the A&E department, and because I'm passionate about the skin, I saw lots of things that I felt other members of the team didn't know as well as I did. So I told lots of doctors that bilateral cellulitis really isn't a thing, and that patient's probably just got what we'd call a red leg. But I also flagged to many of them the skin manifestations of COVID, and talked to lots of staff on wards about the differentiation between a deep tissue injury and what we know is probably one of the inflammatory and embolic consequences of COVID itself. So in the same way that we're seeing increased incidence of DVT, we're also seeing that kind of thing happening within the skin. So we were seeing lots of these little dark purple things happening that will spontaneously resolve. We need to maintain staff health and well-being. And when we talk about PPE, we often focus on the skin, but we must remember that one of the most important ways of keeping the skin healthy and hydrated is ensuring that people are drinking regularly, plenty of fluid. And I'm sure you've all seen situations where if you're going into the full PPE with the full mask, the visor, the long sleeve gown, the temptation is to not drink because the donning and doffing process in itself is quite time consuming. And if you've just gone in there and you find you need to go to the toilet, actually that's quite a complication. But you know yourself, if you are dehydrated, you don't perform as well, you don't function as well, you don't think as well. So maintaining staff health and well-being is about making sure they do drink, making sure they do take a toilet break, and that they take their masks off. And that they're not working 10 days back to back, that they give themselves and their skin a chance to recover. We also need to make sure that we are not conflicted with our infection prevention and control colleagues, so that anything we're thinking about in terms of what we do to prevent facial skin damage doesn't go against what they're doing to help protect us from developing COVID or any other infectious disease. If you do develop skin damage, it's really important that you report it as an incident. But if you are reporting an incident, whether you're using Datex or Ulysses or any other system, please do ensure that you're reporting this as a staff harm, not a patient harm. We don't want to see a rocketing in the patient harm numbers because people haven't made it clear that what they're reporting is a staff harm. You also need to think about who's taking that information on. So I know in different organisations, sometimes it's the tissue viability nurse who sees the harm report, others it's infection prevention, others it's staff health, occupational health, Or it might be dermatology because they're called on to advise on use of steroid creams or specific moisturizers or other things to help manage the skin. But if you know wherever you work, actually people are reporting to lots of different people and nobody's collating that information, it's quite important that you help to pull it together so that we start to see the size of what's happening in terms of damage from PPE. So where does that lead us to? Well, we need to think about raising the profile. We need to make sure that everybody is aware of those that are newly vulnerable, newly at risk of pressure ulcers, those what we call the traditional pressure ulcers on the bottom and on the heel. Those that are in new positions because we put patients into prones. Are we checking their collarbones? Are we making sure when we prone a gentleman that his genitalia are appropriately supported, the catheters in the right place? We need to make sure our staff and our friends who work in other businesses, our colleagues who wear PPE, make sure that they know to look after their skin, that it's clean and dry, and that they moisturize on a regular basis. We have to think about risk management, and that goes back to what I was saying about making sure your workload, your planning allows staff to have regular breaks, whether that's during the day or in the week. Their shift pattern gives them time out of their PPE, and report it appropriately. And we need to think about the long-term implications of this. One of the things that we're only just starting to think about is the impact of pressure ulceration on the face of our colleagues. So if you know anything at all about wound care, one of the things that we know is that if a wound progresses through the epidermis into the dermis, that will form a scar. So if anybody has a pressure ulcer that goes right the way into the dermis of the skin, they will be left with a scar, a physical scar. Now, they might be very small scars, but if they're on your face, they're very noticeable. And it depends on how you view that. Some of them view them positively as their badge of honor. I was there, I did. Others view it as aesthetically very detrimental. Others might see it as something as a cause of mental trauma. It's a reminder of that very stressful time we went through. And we are starting to look what we can do to help both minimize scar and support staff through scarring. And we're working very closely with occupational health teams and others and plastics teams to do that. And finally, we need to really focus on staff well-being, making sure that those who have been through this very traumatic time are supported, making sure that those who feel they couldn't help because they were put in a situation that they were not allowed to go to work and may feel guilty because of that, that are appropriately supported also. So really key, if you're trying to help prevent facial skin damage, keep the skin clean, keep it well moisturized, check regularly. And it's very hard, particularly in this weather. You can probably see I'm quite red in the face anyway. So trying to determine if I've got additional redness is very hard. So look for things that are changes. Don't just use visuals, use your fingers. With pressure ulcers, it's not just about redness. As you know, redness is primarily something that shows on Caucasian skin. In other colors of skin, we don't see redness, we see discoloration. But you will see changes in temperature, you will see changes in texture. So feel, is it soft, is it hard, is it warm, is it cold, and what's that telling you? Make sure you're well hydrated and do take time out to allow your skin to recover. Avoid dressings if possible, as I said, but if you do have to use them, and I know some people will, and it'd be the only way they can continue to work, is make sure that they are as low profile as possible. If you're going to use a dressing, get refit tested so that you know that you are safe, generally safe. And before you do any of these things, make sure that your skin is properly dry. So if you've used moisturizer, if you've used a skin barrier, or if it's like today and you're just hot and sweaty, do what you can to dry the skin, even if that's standing for a few minutes in front of a fan to make sure that your face dries. If you do get a break on your skin, make sure that you report it. And one of the things I'd ask you to maybe pop into the comment box is, do you actually know what to do if you get a break in the skin? Do you know who you report it to? Is there a specific form? Where does that information go? Does your organization feed it into somewhere centrally? And think about what you can do once you've got a break in the skin. Does that mean you can't work in PPE anymore? Or does it mean you can use something different like the hoods? Or is there a different size and shape of mask that you can still safely use? Or do you need to be working in a different area so that you don't need that mask? Think about using things like the tapered silicone foam adhesive dressings, because they've got the nice tapered edge, they've got the silicone adhesive, so you can take them off and replace them every day. make sure that you cut them so they're not stuck all over your face. Also, if you're using the barrier films, be careful when you're putting them around your eyes, because the fumes can be quite painful to your eyes. So in summary, in terms of managing the newly vulnerable, looking after your own skin, the important thing is to recognise what the risks are, to recognise who those at risk are, and to think about what the implications might be. To raise awareness with yourself, with your colleagues, with your family and friends, because everybody is wearing a mask now, and to make sure that we are caring for everybody's well-being. And that may be defending people who are not wearing a mask because they can't wear a mask, as much as it is ensuring that you wear a mask or make sure that your colleagues wear their masks properly. So I'm going to hand back to Alex now, who's got a few slides to round up, I believe. Alex, can I hand back to you, please?
You certainly can. I was just unmuting myself. I have a habit of not doing that. Jacqui, thank you very much. So it was a really, really interesting and extremely relevant presentation. And I've been watching it on another screen here, just following the comments that have been coming through. And there have been many, many comments from the 500 people that have been watching us watching this evening, all saying the same thing. And I've just been thinking quite a lot about the fact that from a pressure ulcer point of view, over many years, there have been various different projects to try and prevent pressure ulcers, as you mentioned in one of the earlier slides. And my worry as somebody that knows somebody that has a family member that has had a pressure ulcer is, from a patient point of view, is whether having nurses be taken away from the roles they're currently in to go and help because of the COVID crisis, whether there's any evidence perhaps of pressure ulcer prevention not getting the care that it really does deserve, because certainly over the last 15 years, there's been a lot of emphasis on taking care of pressure ulcers. And I'd hate to see that fall by the wayside because because people have sort of forgotten about it, because it's not important enough anymore, because everyone's got on the case for COVID. I mean, what do you think of that from a case of people coming in and being admitted to hospital? Are pressure ulcers still as important as everything else that people are now looking at?
It's a really important point, Alec, and sadly one of the things that we don't have an answer to, because in our efforts to make sure that the staff we had were doing the right kind of work, there were some things that we had to stop. And in some organisations, one of the things they stopped was counting their pressure ulcers. We did see in the Nightingale, so for example, in the London Nightingale, although it didn't take as many people as we anticipated, they put an incident reporting team in. So actually, in the Nightingale in London, they reported the highest harms, not just pressure ulcers, everything, of anybody. But actually, that was because there were people going round filling all the documentation in, and the nurses didn't have to engage with it. And any of you that get involved in incident reporting know it's not a simple task. So there's a couple of things. We know certainly with those acutely unwell COVID patients, the decision was save their life or stop them getting a pressure ulcer. We saved their lives. And we know many of them, many more than we would have liked, developed pressure ulcers. We got a bit better as the weeks progressed, as we learned to prone better, as we found better equipment, we prevented a lot more. But there will certainly be some patients who were prone, who developed pressure damage. In terms of the rest of the general population, we've seen, I believe, an increase in sacral pressure ulcers because we've seen a lot more patients with respiratory disease. And one of the ways we prevent sacral pressure ulcers is to keep the head of the bed low, less than 30 degrees. But if a patient can't breathe, we sit them up. So we've seen lots of damage from shear. There was certainly some discussion kind of around the middle of the main COVID period from acute hospitals saying they were seeing patients coming in with significantly worse pressure ulcers, where that patient may have been at home and deteriorating, but not seeking healthcare because they were scared of COVID. So it might not be COVID related. It may have been a patient with COPD or a patient with some other long-term condition. and they were not letting healthcare or social care professionals into their own home because they were scared that they would get COVID. So I think when we go backwards through it, I think we will find there's been a change in the pressure ulcer profile. I hope it hasn't been a significant increase, and I think we'll be able to account for a lot of what happened. Certainly what we're seeing at the minute in our recovery work and in our planning for going forward is a lot of emphasis put on we mustn't lose the numbers, we mustn't lose that protection, that preventative work. And I know certainly things like equipment was still going out. I saw lots of mattress companies still taking mattresses everywhere, and I saw lots of repositioning, but it was much harder because there were different staff. But actually in some of the wards I was on, things like repositioning was happening much more regularly, because if you were a physio or an OT and you couldn't give the drugs, what you could do was reposition. If you were a school nurse and you couldn't do a leg ulcer care, you could go and wash somebody and check their skin and manage their continence. So there were, there were swings and roundabouts about whether good things were happening or whether the ball was getting dropped in some places.
Yeah, and I think that the reality is that you've got the entire nursing population really doing what they were doing, where we know that there were already pressures at work, and then having this pandemic come in and sort of saying, right, okay, now you've got to deal with this as well. And that's where we sort of come into the PPE side of things. And the PPE for me is really interesting because I live in Wales, where we don't have a mask mandate at the moment. So I popped to the Apple store on my week off last week and was given a mask. And it was the first time that I've had to wear a mask in lockdown. And I actually put it on upside down. I was in there and it was dripping down off my face. It was because the little metal clip was I should have clipped over my nose, that potentially could have given pressure damage if I'd have worn it too long, was actually upside down. So that was slightly ridiculous. And I was thinking about work at the time as I was wearing it, thinking, crikey, all these nurses who are having to wear this plus much more. Yeah. Thinking about this event this evening, thinking, this is potentially a real issue. And seeing that slide that you put on earlier, with Amy Gould and Alyssa Bonani, they were in the news. And so we saw those. They were very visual, and everyone sort of had this very guttural sort of feeling around how sad that is. But I think, unfortunately, they are just two people out of many, many thousands who will be in the same situation. So just personally from me, for all of you watching, I really do hope that you are taking care of yourself and actually taking care of or taking note of what Jacqui mentioned this evening about making sure that you know what mask you're wearing, and that if it's been fit tested, making sure that once you've had your fit testing, that you are still wearing the same mask. Jacqui, I could talk to you for hours about this, but we've had lots of questions coming in, and there's been, as I said, been 500 people watching this evening, so we're not going to be able to get through all of the questions, but we are going to go to the live Q&A now. For those of you who we don't get through the question, or for those of you who don't get your question answered directly this evening, we will endeavour to come back to you directly. What we tend to do is at the end of this, we put an edited version of the presentation and the video on our website, along with a document which has all of the questions and all of the answers on there as well. So the first question to you, Jacqui, is from a dear friend of ours, from Dale Copson. Should COVID-19 be incorporated into pressure ulcer risk assessments going forward, so we do not miss the newly vulnerable patient?
Thanks, Dale. That's a really tricky question.
Sorry, and I promised you that the first one wouldn't be tricky.
Yeah. It's kind of hard to say because COVID in itself doesn't increase the risk. It's teasing out the factors of COVID that increase the risk. So, was the patient on inotropes? Was the patient nurse prone? Was the patient ventilated for long periods? Did they have acute respiratory distress? So they're required to be nursed in that very upright position. Now, some of those things you could say are picked up in some of the risk assessment tools already. So if you're in intensive or critical care, you might be using a risk assessment tool like Calculate or Cubbin and Jackson, both of which have presence of inotropes in there, ventilation, use of respiratory support in there. If, however, you're now home and in the community, we don't know the long-term impact of that. We don't know what the washout effect is on those inotropes, what effect they'll have on the patient's skin. Hopefully, once they're off them, very little, they tend to clear through the kidneys very quickly. But I think what we will see are those more psychological impacts. We will see people almost getting post-traumatic stress or getting depression. And those are elements that are not picked up well in risk assessment tools. If you look at one of the reasons why people become less mobile, depression is a really key one. Anxiety is another. People retreat into themselves, they don't go out. So I think consideration of having had COVID or being impacted on by COVID, because I think as many people will be impacted on who didn't have COVID, but were shielded, so they changed their routine, they will have become very insular. They will have not been beyond the boundaries of their own home for 15, 16 weeks. And we know that if a patient's admitted to hospital and put into a hospital bed, they lose something like 10% of their muscle mass within the first few days. But if you imagine being stuck in your own home, unless you're going to do Captain Tom and walk round and round your garden every day, you're going to be losing muscle mass. You're going to be your weight changing. There's a whole host of other things that may happen. So the impacts of COVID in terms of risk are phenomenal.
Yeah, but I think the other thing to consider there is we're all very hopeful that COVID will be a thing of the past in the not so distant future, and we all have different views as to how long that will be. And the implementation of change within the NHS generally on a local level or on a national level to be able to sort of incorporate that sort of thing for something that I'm hopeful that will be gone within a couple of months. It may be quite a big task to be able to do it. Certainly people need to be aware of it currently. But it's a great question, Dale. Thank you. So the next question is from Bernadette, and this is, what advice with wearing gloves? My hands are macerated with the amount of moisture, especially in the current heat wave.
Yeah, I mean, that's a really tricky one because it's the temperature that's causing us problems. So really simple things: only wear the gloves if you have to. Do not double glove. Don't wash and reuse your gloves. So we're still seeing people having gloves on, gelling their gloves and continuing to use them for something else. So make sure you regularly change your gloves, you wash and you dry your hands properly. And I would say change them more frequently than usual. And really think about, do you need to be wearing gloves? Have you got the right size of gloves? So if your gloves are too tight, they will make them even sweatier. Making sure that you are moisturizing at the beginning and the end of the day, and use it at night in particular. Use a really rich hand cream. Get the best one you can and moisturize. And sometimes sleeping, even though it's hot, sleeping with the cotton gloves on, and that helps it to absorb. Don't overuse gel, because gel, once your skin is slightly macerated, will start to penetrate the skin and cause more problems. You'll get lots of cracking and if nothing else, it's like when you've got a paper cut and you put your hand in a baguette of crisps, it really hurts. So try to avoid that kind of pain. Avoid using powdering gloves if you can, because that really doesn't help and it causes a lot more allergies. So you're far more likely to be sensitized if you're using powdered gloves. And really, it's just the common sense things that you can try to do is, if you don't have to wear them, don't wear them. Wash your hands instead. And certainly don't double glove. Make sure your hands are dry when you put them in, and wear them for the shortest period possible.
Okay, thanks. So there's been lots of questions or lots of comments really around sort of condensation and the challenges of wearing a mask, especially with glasses. Yeah, especially with glasses. You're probably exactly the same as me. Like I said, I had 10 minutes in the Apple store the other day with problems with it. What's your best advice? Although saying that, I mean, I've seen lots of stuff on YouTube and things, and actually the BBC put a video out just recently about how to best wear a mask with glasses and things like that. But what's from your experience?
I mean, as I said, the problem I had was the putting them on and off. So if anybody sees me not reading, they're permanently on my head, and if I'm reading, they're down. So they're up and down and up and down. And if you're wearing a visor and you're trying not to touch your face, that's really difficult. So I managed to find a disposable, not a full visor, but a half face visor that actually, because it was quite flimsy, I could drop my glasses on top of and still see through. But that then did start to give me problems, because it meant that the visor was pressed against the top of my mask, and I was getting more steaming up. So it is about good fit. It's about making sure particularly the bottom and the sides of your mask are fitting well, so that you shouldn't be steaming up, because your breath shouldn't be coming out the top of your mask. And depending on your face shape, it's different advice. So for me, I sit my glasses really firmly on top of my mask. It sits really well here. But I know for my other half, he wears his slightly lower down, still over his nose, and he's got shorter glasses than me. He's got, the more straight style, and he doesn't let his touch his glasses. So some of it is just trial and error, working with what works best for you. And I've also found that if you sometimes wipe an oil, a very fine oil on the inside of your glasses, it stops them fogging up.
Yeah, so I saw, for those people who were talking about that, I saw a video on it was on the BBC, and it was just a few days ago, and it was specifically about how to prevent fogging up of your glasses and things like that with while you're wearing a mask. And I think that'll probably apply to the face covering, the whole face covering situation. So Kirsty says that she hasn't heard of anyone reporting skin damage from PPE. How can we make this easier for people? And before you answer that, let me just sort of expand on that question, because obviously you did part of your presentation showing that there's skin damage being reported from wearing PPE. Should there be, is there education that you're aware of out there specifically aimed at nurses about how to wear PPE correctly? But also from a patient point of view, is there enough education out there from patients and actually patients' families and patients' carers to help prevent skin damage and pressure damage?
Is that a very multifaceted
big question?
Yes, there is information for nurses on skincare. So there is that NHS England and NHS guidance. If you Google NHS England, PPE and pressure ulcers, the guidance will come up that tells you just the steps that I said already. And for patients, there is some really good videos about device-related pressure ulcers. So much more around your CPAP mask, your BiPAP mask.
Yeah.
But there's a series of videos that I think is in the link on one of the slides. But again, if you go to YouTube and Google the Stop the Pressure YouTube channel, you'll find those there. But there isn't very much for the general public about skincare under masks. And I do worry when I see the way people wear the masks. So like many of you, I went out today to get some bread, and there was somebody in the shop and they've got their mask under their chin in the car. So what they do is so I understand what they do is they keep it on so they don't forget to put it on. But actually when they wear it, it fills up with sweat, and then they tuck it under their chin, and then all that sweat sits against their chin. So they get quite rashy skin. And they fold it up and they put it in their hands and they put it on tables, and they do. I really want to just go to people and go, just let me put that in the bin, because I've seen what you've been doing with it. And I don't think the general public really understand what impact it can have on the skin, particularly if they've already got skin conditions, if they've got acne, if they've got eczema or psoriasis. You'd think people who've got those conditions would be good at skincare, but they're not seeming to see that this kind of occlusive covering we're putting on the skin is making it worse, particularly in this heat. And we couldn't have predicted that we would have this heat, which in some ways, I don't think we would have made it through COVID without this beautiful summer. But when we've reached this point now, is actually quite frustrating. Did I answer all the bits? Or did I miss?
Yeah, no, I think you did. Yeah, I was thinking about. I was thinking, from a personal point of view with regard to education for patients. Just because my I won't go into it, but my brother is epileptic and ended up in a hospital situation where he really needed to be turned regularly, and they weren't doing it, and there was no advice around for sort of. I guess that now I'm thinking about that out loud. I'm thinking that if you started sticking signs up in hospitals like that, that's almost telling sort of patients and carers how to do the nurse's job. So I wouldn't recommend that. But yeah, no, sorry, just thinking out loud.
Alec, we are particularly during COVID, we've seen some real benefits to COVID. So many of us have been trying to get digital technology through hospital governance systems and through all the red tape. Can we do video consultations? No, it's too complicated. We hit COVID. Look at that. We can do video consultations. How many of us are using Teams or Zoom? We've been trying for a long time to get patients more involved in their own wound care. You know, we believe it's the patient's wound, they should be involved in it. It's the patient's risk, they should be involved in it. And what we saw during COVID is because patients didn't want to see us because they were worried, suddenly they were doing their own dressings. We might be doing a video with them to explain, we might be giving them information, but they were doing it. And there's a whole suite of resources now on the National Wound Care Strategy page to help support patient engagement. It's primarily about wound care, but we're developing some for pressure ulcer prevention. And you know, it's about making sure that the patient and the family know why they can engage and are capable of engaging. It's also about personalising it. So one of the London TBNs did a piece of work where she looked at giving leaflets to patients in hospital. And then 3 weeks later, she rang them at home when they'd been discharged and said, do you remember what we told you? And they didn't even remember having a leaflet. And they changed it to having a single sheet that had the patient's name on and had the very similar information, but it said, at the minute, you are in the red group. If you go into the green group, or you're in the green group, you're not at risk. These are the things that will make you become red. If you are red, that's a red flag, contact your nurse. And when she rang them 2 weeks later, they all knew. They all knew what they had to do because it was personal to them. And they understood that some of the risk management were things that they could do.
Yeah, I think there's just, like for me, I think that the link between sort of patient education, certainly from chronic conditions, and nurse education, really, there could be a lot more sort of synergy between it. Jacqui, we normally would finish by now, but if you don't mind, I am going to ask you one more question, just simply because we've still got 420 people watching, and it's rare. That's amazing. Well, and it's rare that we get someone. No, it's rare that I get to talk to someone as esteemed as you. I won't say I shouldn't say that because it may sound disparaging to other speakers who I'm very, very fond of. But from a final question, what was your personal experience like in working in ITU during COVID?
I wasn't in intensive care, I was in a COVID transfer team. So we specifically took patients from ED onto admission wards into their main wards. There was a critical care outreach team who took those critical patients. And we did move some very sick patients. And I can remember there was one of my first questions when I went into the organisation was, what do I do if the patient dies halfway there? Because we moved some very sick patients, and there were patients that we ran. I mean, we really ran, and we had lifts held ready for us. And I would say my first week was scary. It felt chaotic. It was when there was all the fuss about had people got PPE, but in reality, we did. I can hand on heart say the organisation I worked in didn't seem to have a problem, and we didn't seem to have a staffing problem, and we were really well supported, and things seemed to happen properly. Wards were redesigned and screens were put up, and patients were cohorted and extra teams were put in, and it was pretty smooth, pretty slick.
Oh, good.
I was impressed with it. Even if I did have to do shifts that finished at 2:30 in the morning and then come home and have a shower before I went to bed.
And even if you had to wear PPE too much, too hot, too long, all the rest of it.
Because I loved going around and I'd suddenly see posters appearing that I knew that, we'd done the guidance and the TBN had got it, and I'd see it there on the walls and people would ask about it. It was really heartfelt that, it was getting out there and people knew about it.
Yeah, Jacqui, I just want to thank you deeply for joining us this evening and for doing this presentation. I know that certainly from the comments that we've been getting, a lot of people have found it extremely useful. Just to conclude, I'd like to thank Mölnlycke for supporting this evening's event. I'd like to thank each and every one of you who have joined us this evening. Mölnlycke have very generously offered to provide a Mepilex Light cutting guide with information on pressure ulcer prevention, or if you'd like information on pressure ulcer prevention, or you'd like to speak to a local Mölnlycke clinical support team, then an email address, a telephone number, and a website should be on your screen right now. thank you again, everyone, for joining. We're going to be putting up lots of different links for useful resources for some of the things that we've mentioned this evening in the presentation with regards to latest government guidance on COVID-19. There's going to be some useful videos from the Stop the Pressure team, and various other things which you'll be able to request from us directly and from Mölnlycke. Jacqui, thank you again for this evening. I really hope that we can do more of these together. I will say good night now. Thank everyone again for joining us, and good night.